Welcome, everybody. I'm Girish Chindia, President and CEO of Aveshka. And I want to welcome all of you, all of Aveshka employees, as well as friends, family members, and other colleagues. We like to open this to members outside of the Aveshka family because of the importance of this topic as it affects all of us in our daily lives, whether at work, whether our kids at school, whether in social activities and otherwise. Just a little bit of background on Aveshka. We are heavily involved in COVID-19 response, ranging from mission critical federal programs at Department of Health and Human Services, as well as the Centers for Disease Control. We also support and counsel many commercial organizations as they wrestle with how to get back to work in a safe and sound environment and bases. Today's town hall will feature a group of our subject matter experts sharing the latest on COVID-19 and providing guidance in this ever-changing environment and situation. This is the same public health team of experts that advises our clients both in the federal sector as well as the commercial sectors of engagements. We do these town halls periodically because of the ever-changing nature of COVID-19. We want to provide you with the latest and greatest crucial information to deal with our daily lives. As I said earlier, we have also opened this up beyond our employees because we feel this is very important information to share with our community. So we welcome, again, as I said, friends, colleagues, and others to come in and be part of this town hall session. This session is led by Dr. Til Jolly, who is our Chief Medical Officer at Aveshka. Dr. Jolly is a board-certified emergency physician. Somebody please mute themselves, thank you. Physician with over 25 years of experience encompassing bedside clinical care, academic medicine, healthcare preparedness, telemedicine, and risk communication. So as you can see, he is very well suited to advise and guide us on this ever-challenging COVID situation. With that, let me turn it over to you, Til.
Thank you, Girish. And I'm going to make a few opening remarks, and then our team will go forward. Thanks and thank you to the Aveshka family who's joined us, and also thank you to those outside friends and colleagues who've joined us. We hopefully you'll learn a lot, and we'll happily take questions on things to know and learn about COVID. As usual, there's a lot to review and talk about, a lot of changes. First, I really want to thank everyone for the work you've done so far. Many of you are experts at preparedness issues, but you didn't really plan for this. And for over a year and a half, you've lived through some challenges at work and at home and your professional and personal lives that have really pushed you. And I really want to thank all of you for the work you do on behalf of Aveshka and on behalf of all of us. Today, we're going to share some progress and some good news, but also some challenges that we're continuing to face as we move forward. We will readily admit there's just a lot we don't know, and we're learning about this every day, and we live it every day. We're going to hit some of the biggest current issues, not all of them, and answer a few questions. I'm joined by Dr. Michael Anderson, who's going to speak in a few minutes, and Dr. Emily Lankau, who's going to speak now about some of our data. So I'm going to turn it over to Emily. Emily?
Thanks, Til. If we can go to the next slide. So we always try to give you key takeaways at the beginning because a lot of times we put a lot of data out there and a lot of new information. And our key takeaways are pretty simple this time. COVID-19 is still with us. And we know that vaccination is still the way out of this pandemic. And we'll talk about some nuances of how vaccination is being applied and some new things that have been discovered about vaccination and booster shots, et cetera, down the road. But we want you to understand that we're making progress. And while we're not there yet, we've come a really long way from where we were last year when we didn't even have a vaccine to work with. And finally, there are still many unknowns. And so we really are recommending clients and the Aveshka family stay informed and keep track of what's going on nationally and locally so that we can try to keep folks safe until we get this virus under control. Next slide, please. So COVID-19 is still with us. I know we all know that, but it's important that we look back across this outbreak and get a sense of where we are now. And that helps us sort of sit in place and understand things. We use the slide with clients regularly. We update it every couple of weeks. And this slide shows us on the bottom, the line graph of the epidemic curve of cases being reported through time. And the very end of that graph shows us where we are now. And the first part of the graph shows us where we were previously. The inset figures are showing you the 14-day case rate over time, with a dark red being really high case rates and a light or white color being low. And what we see is that while we're not as bad as we were in January of 2021, we're still much worse off than we were in October of 2020. The good news is that we're coming down from a peak now and heading towards levels of case rates that are lower and more acceptable for getting around and interacting with other people without transmitting the virus. But we still have a long way to go to get to acceptable case rates that are really functional for us to be living with this virus without spreading it to others. Next slide, please. There are 3 barriers to controlling COVID-19. Some of these are in our control and some are not. So the Delta variant, you can see on the left, has gone from being a minor or part contributor of our viral pool to being the dominant virus across the country. We're now at 99+% of all sequenced viruses and have been that way for months. Delta is highly infectious, so it spreads readily to anyone who's unvaccinated and occasionally to people who are vaccinated too. The second barrier is low vaccination rates, and this is occurring both at a state level and occurring at a local level. So when we look at this map, light colors tell us that the low vaccination county, dark colors tell us it's a high vaccination county. And you can see there are patterns where some states have higher vaccination rates overall, but even in those high vaccination states, we still see pockets of low vaccination that are possible entry points for new variants and for viral spread. We have vulnerabilities across the country because of low vaccination rates. Finally, our behavior. We have gone back to somewhat normal operations, maybe a little too soon. And so people are interacting in a space where there's lots of virus circulating and precautions are not always being taken. And this has contributed to the wave of virus spread that we've seen over the past couple of months. Next slide, please. The good news, and we try to give a good news, bad news story. The good news is that vaccination has reduced the number of older adults being infected and hospitalized substantially. So the figure in the middle shows you vaccination, fully vaccinated over time, and it's split out by age. And so if you look at our older population, our 50 plus in purple, you can see that we've gotten to fairly high vaccination rates for those populations, and they are our most vulnerable when it comes to illness and death from COVID-19. We have not made as much progress with our younger adults or our young folks who haven't had as much time to get vaccinated, and they are still at much lower vaccination rates. And this is now playing out in what we're seeing with Delta spread. The figures on the right-hand side show you what these curves look like for hospitalization for different age groups. And we've pulled out the 75 plus, approximately the 25 to 39-year-old population, and then our younger kids from 0 to 17. And if you look at September of 2020, you can see that really our dominant population that was being hospitalized was our older population. And they had a very steep rise in hospitalizations in September that went on through the Christmas holidays and into February, March, coming down. What we're seeing now is very different. In June, July, we started to see an uptick in hospitalizations, and it's predominantly in our younger populations. The increases that we're seeing in older populations are less steep and less severe. And the good news story is we're not seeing hospitalization of our most vulnerable people, our older people who are most likely to have severe disease and die. And what we often tell clients is think how bad this would have been if we had not had vaccination on board before Delta hit. Now, we don't like seeing younger people getting sick and being hospitalized either. So we still have work to do to bring case rates down and bring hospitalizations down so that people are not being infected with this virus. The good news is it could have been much worse if it weren't for vaccination. Next slide, please. So I'm sure everyone is seeing these figures. I pulled this from one of my colleagues who sent it to me just as an example. Every hospital in the country is trying to communicate to folks just how important vaccination is. So this hospital has done that with this little icon graph. We're seeing these all over the country, and anecdotally, we see these graphs that show us that most COVID-19 hospitalizations at any given hospital are unvaccinated persons. Some vaccinated people are getting breakthrough infections. A small percentage of them are getting severe infections and having to be hospitalized, but very few to none of them are in the ICU. Most of those are inpatient hospitalizations. The other key point we're seeing hospitals making is that most of the breakthrough cases that are hospitalized are in older populations, people who had their vaccines early or may have immune systems that did not respond as strongly to the vaccination. And these are important messages for us to understand on both the local hospital level to understand the populations that are being affected by breakthrough infections and severe illness, but also for thinking about vaccine effectiveness. Next slide, please. Now, we know recently CDC has looked at these data across multiple studies at more of a population level, and what they've seen is exactly what we're seeing in these local hospital figures that are popping up all over the country. Over time, vaccines are still extremely effective at preventing severe illness and death. They are less effective at preventing infection over time, and that seems to vary a little bit between Pfizer and Moderna in terms of how quickly that efficacy is dropping off. The figure below shows you specifically for hospitalization that while we do see some differences in hospitalization effectiveness from vaccines and a little bit of a drop off for some populations, these vaccines are still highly effective at preventing severe illness and death. These are all data that play into the decision that CDC and FDA have been working on for boosters. And so the decision to vaccinate people at very high risk of exposure, like hospital employees, people who are older than 65, people who are in long-term care facilities, and people who have underlying health conditions, comes directly from this evidence that vaccines are losing effectiveness over time for infection to some degree, but they're still very effective at preventing severe illness, except in some subpopulations that are already at high risk. The overall message for the general population is vaccines are working. They're preventing infection in most people. They're preventing severe illness and death in most people. And some people need a little extra protection. And I know my colleagues will talk more about boosters coming up. Next slide, please. Another key message is that vaccines are saving lives. So this figure simplifies the national picture down to two key numbers. On the left, just over half of the US population is currently vaccinated. It was 56 or 57% last time I looked, and it's been slowly creeping up. On the right, this is an amalgam of a number of numbers that we've looked at, but somewhere between 0.1% to 5% of deaths at the end of August were vaccinated people. Now, if vaccines were not preventing deaths, we would expect these bar graphs to look very similar. The fact that they are so different tells us that vaccination is really keeping people who are vaccinated out of this pool of individuals who die from infection. And that is really, really good news. Next slide, please. Now, one of the things that's been really challenging for our clients and for all of us is the fact that the situation is really dynamic. And what we thought was true a few months ago has changed as we've seen Delta take off in this country. I'm going to do a little math, but the math helps us understand why vaccination is incredibly critical. It's necessary for controlling this virus, but it's not sufficient to do it alone. On the first row, we have a number called R0, and R0 is the infection rate, or how many people an infected individual will infect on average. The original SARS-CoV virus infected approximately 3 people per infected individual. If you do some math to look at how you can prevent infections, you can get to something called the R effective, which tells us out there in the field how many people are people really infecting. So R0 is inherent to the virus. R effective is what's going on out in the field setting when we do prevention measures. If 50% of the population is fully vaccinated, the math works out to reducing that R0 down to an effective R0 of 1.6. At that level for the original virus, vaccination plus preventive measures for the unvaccinated may have been enough to control that virus. Fast forward now to Delta. Delta has an infectivity of 8, which is nearly 3 times that of the original virus. With a 50% population vaccination permeation, we get down to 5, which is not even what we had for the original virus. So this is an extremely infectious virus, even after we do vaccination of half the population. And this is why the guidance keeps shifting, because what we've discovered is we need to get more people vaccinated, and we need vaccinated and unvaccinated people to partake in these non-pharmaceutical interventions like masking and physical distancing to get a handle on this virus. Vaccination alone can't do it, but vaccination plus prevention measures has a really strong likelihood of getting this virus under control. We have to do both. And that's been frustrating, watching the guidance shift when we thought we knew what was happening and we thought we could do things in a certain way, and now we have to pull back and rethink these things. Next slide. So where we are right now, and one of the key messages we're sending to clients is until children can get vaccinated and until we can get boosters into folks who have lower immunocompromise or lower chance of responding to vaccination or maybe higher health risk, we really have to do everything that we were doing before, getting more people vaccinated, masking when indoors, including our vaccinated population, doing physical distancing and cohorting in schools and camps, respiratory and hand hygiene, ventilation, and testing and contact tracing. We need to use all the tools to protect the populations that are still not protected. And that is a frustrating message because we were hoping that vaccination alone would be enough to help us get control. We talked a lot about herd immunity, and truthfully with Delta, we need to do more. Vaccination is necessary, but not sufficient to get this virus under control. Next slide, please. So I'm going to end with just a general concept we talk with clients about a lot as well, that as we move into a phase where we learn to live with this virus, we need to recognize that there are lots of things that push the curve up and lots of things that push the curve down. And these differ regionally and locally across the United States. So this is a complex figure that comes from the White House report. And the way to look at it is these are just epidemic curves for each state, giving you a sense of who's going up, who's going down, who has really high case counts, who has lower case counts. And so the dark red that are going up are the ones we're really the most concerned about. The ones that are lighter colors that look like they're sloping down are places that are improving. And the message I want you to get from this is that it's all really variable across the nation. We have places that are improving dramatically right now. We have places that are at very high case counts and still increasing. And we have places that are actually coming down to safer levels for getting folks back out into the community and interacting. And this is what we might expect. And I know Dr. Jolly is going to talk a little bit about projecting into the future in the holidays. We might expect that we see this pattern for some time where there are hotspots in some parts of the country and some parts of the country are resolving and settling back down. And one of the things that will drive those patterns is vaccination. The other thing is behavior. So we do have some control in this to try to control what happens to our future, but we have to do it collectively. And that's a hard thing to do. Next slide. So there are many days after a year and a half of this, I feel powerless. And so I want to leave you with something that you can do, because we all have power over this outbreak, even if we can't stop this virus individually. So 5 things that you can do: get vaccinated, encourage your friends and family to get vaccinated, get boosters if you are eligible, follow your doctor's recommendations, use masking, physical distancing, and hand washing at high case rates according to CDC guidance. If you're in a substantial or high category, keep those masks on in public or in very crowded venues. Prioritize your family's physical and mental health, including getting your flu shots, and also pay close attention to mental health. This has been tough on everyone, and staying connected and looking for ways to stay close, even if you're physically distant, is really tough, but it will get us through this. Continue to make decisions based on data and guidance from reputable sources. So keep looking to CDC and other public health officials. They are doing the best they can to get good guidance out as quickly as possible. And be patient. Right now, we're in a very strange period of this outbreak where we really just need to sit and watch and wait and see what happens next. And that is very difficult to do. So I'm going to pass this to Dr. Anderson. He's going to give us some more specifics about kiddos and treatments, and help us kind of get a sense of what else we can do to have power over this outbreak. To you.
Emily, thank you so much. Dr. Lankau was always a tough act to follow, just such a well presented story about good news and bad news. And it's an honor to be with my Aveshka friends and family. My name is Mike Anderson. I work at the Assistant Secretary for Preparedness and Response. And quite frankly, the things I focus on is in really 2 big buckets. One is COVID therapeutics, and the other is pediatric issues. As a peds ICU doc, but more importantly, as a father and a grandfather, I'm really concerned about how this pandemic has and is continuing to affect children. So we'll talk a little bit in those two buckets of therapeutics and kids issues. Next slide. This is a graphic we use at the federal COVID response. You see at the bottom, this is from HHS aspirin. This is how we think about patients progressing with this horrible, horrible disease known as novel SARS-CoV-2 or COVID-19. It's a little chevron to the far left, the light blue, but so much energy has gone into preventing people from getting this disease. And that's all about vaccination. And Emily pointed out just so well what good news it is that we have several EUA approved vaccines. And now we're even getting to the point of talking about boosters. Just imagine how horrible this would have been if pharmaceutical industries and academic medical centers and researchers hadn't really risen to this. So a lot of energy and focus on vaccination, but unfortunately, whether it's the politicization of politics of this all, whether it's misinformation, we know that there's a large percentage of this country that is still not vaccinated. So people are going to progress from left to right along this clinical course, unfortunately. And once again, the strength of this country, of pharmaceutical, academic medical centers, clinicians, and researchers coming together has brought out new products each step of the way. We now have what's called post-exposure prophylaxis. Can you see it in the red, where we can give monoclonal antibodies to folks that are either not vaccinated or have not mounted an adequate vaccine response and they've had a high risk exposure. We now have PEP indications for these monoclonal antibodies. The next segment is a really concerning group of patients. Those patients have turned positive for novel SARS-CoV-2, but they're not sick enough to be hospitalized. And up until 9-10 months ago, all clinicians had was really hope and prayer, send people home with hydration, maybe Motrin or Tylenol. But now with 3 EUA approved monoclonal antibodies, we do have therapy. We do have therapy that is incredibly effective at decreasing the need for hospitalization. That does a number of important things. That saves patients' lives, and that starts to lessen the strain on a really strained healthcare system. You can see them listed below. Once again, 3 EUA approved monoclonal antibodies. The good news from our work at the federal COVID response is these have really become a part of the infrastructure of modern healthcare in record time. They have gone from EUA approval to now being available for to patients on a very quick basis. And the Regeneron product is also available by subcutaneous administration. The other 2 products by Lilly and GSK are intravenous alone. So we have seen centers across this nation stand up monoclonal sites, and I know they've saved lives and helped preserve capacity. One of the operational issues we've dealt with, however, is setting up an IV infusion center, setting up even subcutaneous administration. It is really quite difficult, has a lot of infrastructure, a lot of costs, a lot of personnel. So you can see asterisk at the top, and I labeled it potential for a reason. Merck has now put forward an EUA application for an oral antiviral for this same sort of middle bucket of patients that are positive for COVID, but are not sick enough to be admitted. This could be a game changer for clinicians because it's a lot easier to administer than IV or sub-Q, and the ability to get this into patients in a much more rapid fashion, I think is absolutely terrific. I'm not going to talk much about hospitalization, about what goes on in the ICU. Suffice it to say, this is a bad disease. We have to fight the misinformation. Way too many people have died from this. I live in Washington, D.C., and when there was that memorial on the mall with a flag for every American that had died from this disease, to see over 700,000 little white flags just brings home the enormity of the cost. And yet the fight continues. And those of us in the public health sphere have to continue this fight to save as many Americans as possible. Next slide. This is just a couple of headlines you've seen in the press. Merck put out its press release on this new oral antiviral. Seems to cut the risk of progressing or being hospitalized or seeking ER care by upwards of 50%. The monoclonals are about 70%. So we are going to have some interesting, I think, clinical questions that us docs and nurses and practitioners and pharmacists are going to have to ask and answer. But I find great hope in that there is an oral pill being reviewed by the FDA. So I put an asterisk. This is potential, but the fact that we have another tool in our toolkit to fight this horrible virus, I'd go back to Emily's good news and bad news. This to me is good news. This means that we have another tool for clinicians to fight this horrible disease. And once again, hopefully an easier route of administration than IV or subcutaneous. Next slide. So I'm going to turn a little bit to children. I'm, as I said, a pediatric intensive care doc, and there's been a lot of misinformation. Kids are immune. They haven't been affected by this. Well, that's just plain wrong. There is some good news. Kids do get less ill if they get infected compared to adults. But boy, we've seen some bad trends over the past couple of months, a large spike in Delta cases, as Emily alluded to. We've seen in several areas of the country the fact that kids under 17, new cases have passed adults for a number of new cases in particular regions. That's really disconcerting. And if there's any public service announcement, any bit of data that my hope is can turn even the most ardent, I'm not going to get the vaccine, whatever the argument is, we know in those areas of the country with the lowest vaccination rate, we've seen the highest number of kids turning positive for COVID, and worse yet, the highest number of kids seeking emergency department care and being hospitalized. And thank God it's rare, but it's not unheard of. I was at an intensive care unit last week on behalf of ASPR in California, saw a 4-year-old on a ventilator with COVID. There shouldn't be any 4-year-olds on ventilators with this disease. And we'll talk about vaccine in a minute. So it's good the number of cases are low, but I remain concerned that they're not zero, and we've seen a significant increase in Delta. The end of this slide, the last bullet, is the good news. The good news for me, once again, as a pediatrician and a parent, is that Pfizer has submitted EUA request, ages 5 to 12, for a series of immunizations for children. I think it's on my next slide, if we could go there, please. Sorry, this is just the data that shows your likelihood of needing hospitalization, needing ER care is some 3-fold higher in the lowest vaccinated parts of our country. So once again, if we need to design any messages for folks that are still so against this vaccine, what's more important than protecting our kids? There's nothing more important than protecting our children. And we have real live, well done data that shows kids are much more at risk in those under-vaccinated areas. Next slide. Children's hospitals are at risk. Children's hospitals, I've been a part of children's hospitals since I was 18. And boy, like many parts of our healthcare system, they are really hurting. We've had an early and harsh RSV season, another virus. The mental health crisis is just that, a mental health crisis. The number of kids that are suffering because of this pandemic. The mental health crisis was bad going in. I think the pandemic has only multiplied that. I was on the phone with a coalition of children's hospitals the other day, just sharing what they're undergoing. They're at 90%, 104%, 110% capacity in their hospital. And I heard a really disconcerting statistic that they screen every kid coming to the hospital. Whether you're having a well child visit, you've got a laceration, or you're just seeing your ENT doc, they screen you for suicidal ideation because of how tense this country is right now. 15%, repeat, 15% at this one children's hospital were tripping positive for high suicidal, high suicide ideations. That's just totally unacceptable. It's a horrible number for kids. It's also a strain on those children's hospitals because you can't just let that child go home. You've got to bring out resources to assess, are they safe and what do they need to do? So the mental health crisis is something that children's hospitals alone can't figure out. It's going to take government, it's going to take academia, it's going to take all of us to support kids at this really tough time. This is nothing new to healthcare over the past year. The children's hospitals are feeling the same the same tug at their heartstrings. Clinicians are burned out. They're just so tired of this all, and morale is really, really fragile. So we have to make sure that 2%, repeat, only 2% of American hospital beds are children's hospitals. We have to make sure that they're preserved and supported. And it may be a very long fall and winter, because the other thing that Emily briefly alluded to is we don't know what flu is going to be like, because we're not masking as much, because barriers have started to go down. I don't think we're going to see the protections we saw, almost an absent flu season last year. So they call it the twindemic. if we have flu and continued Delta, I think our health system is going to be strained even harder. Next slide. And this is just sort of some headlines of the terrible surge that we're feeling. Next slide. I do want to end with some good news. And to me, once again, as a pediatrician, a dad, granddad, I think it's terrific that Pfizer has brought forth data to the FDA for ages 12 to 5. They've looked at the dose of the Pfizer vaccine against novel SARS-CoV-2. They've looked at the safety and they looked at the efficacy. And I think this is a really important time for kids. It's going to put even more strain on pediatricians, on children's hospitals, on family medicine docs, on community health clinics. How do we get these kids vaccinated? I think it's up to everybody that's on this town hall. However, we've got to rally for our kids. This is a dangerous disease. We've got to get as close to herd immunity as possible. We don't want another variant to emerge. And I think the conversations between pediatricians, their patients, and their families is going to be really important. I know a question will come up. I think, and this is just Mike's conjecture, no inside baseball information. I think shortly after Halloween, we'll start to see the approval from FDA, and then the race is on to get as many kids vaccinated as possible. The data from age 5 to 6 months, I think will be a couple of weeks, if not a month or so behind that. Once again, I think that's really good news for kids because this is a terrible, terrible virus. And I'm so glad that Pfizer has come forward with this EUA application. I think, Dr. Jolly, that is my last slide. Look forward to questions. Thank you so much.
Thank you, Dr. Anderson. I don't have slides. I just have a few things I'm going to touch on, and then we'll go to questions. A couple of issues, and thanks. Those are 2 tough acts to follow. Great expertise on a lot of tough issues that are key to getting us out of what has been a long and frequently painful pandemic. A couple of things to talk about that I just wanted to touch on. One is boosters. You've heard them mentioned. And we've talked about boosters for a long time. In fact, we early on, all of us, as we were talking through vaccination, we were saying to our clients and our families and friends and everybody, boosters or extra shots or whatever you want to call them will be part of our armamentarium. And they really are for other shots also. We see this with everything from hepatitis to tetanus to you name it, having to get shots for boosting effect at one point in time. Currently, there's approval, as Emily talked about, for a 3rd shot for those who are immunocompromised. And once again, if you're immunocompromised, you know it. You have a medical condition, either primarily or because of drugs we've given you that has created that, or age-based, because we know that our older adults don't have as good immune response and need that extra. And then those in high-risk occupations. And that's for the Pfizer vaccine, simply because the Pfizer vaccine was the first one out of the gate. The other ones are probably not far behind. And once again, as usual, we have news. I just saw a news flash about something related to the J&J vaccine, but this will come with time. And don't be surprised if this happens. So far, the side effects we're hearing about are similar, the 3rd shot versus the 2nd shot. Not a surprise there also. But realize that we talk about boosters, and I want to make sure everybody understands, immunity is not an on-off switch. It's not right like you reach some point where suddenly you're not immune. It's a gradual waning. If you've been primarily vaccinated, you still have remarkable immunity against COVID. And so you shouldn't worry that your time hasn't come for a booster. You've done the main thing, which is get primarily vaccinated. And from a community and a public health standpoint, we talk a lot about boosters, and it's unfortunate, actually. Now it's good that we're getting a lot of boosters out in the community, but boosters are now passing primary vaccination as an injection volume. We need to get people primarily vaccinated, and that's really continuing to focus. One thing that I got asked to talk about was predictions for the future, and with holidays coming, we kind of joke, we get asked if we have a crystal ball a couple times a week by our clients, and I've nearly bought one as a prop. As I've said before, if anybody tells you they know exactly what's going to happen, you probably should stop listening, because nobody knows exactly what's going to happen. But we can project some things, and the holidays are coming. We know Halloween is very important, Thanksgiving is very important, and then the holidays after that in the coming months are very important. There are times for family to gather and kids to gather and friends to gather. And they're important for many reasons. They become, the calculus around this and the calculations around this become about calculating risk and looking at things that are high risk and things that are lower risk and trying to reduce the things that are high risk. And sort of the things that are high risk are obvious. Getting lots of people who are unvaccinated together is inherently dangerous. We know this. And however, it can be mitigated by masks and being outdoors, but we need populations vaccinated. Purely indoor gatherings and crowds are worse than outdoor gatherings. And so to the extent that you can do things outside, happily, most trick-or-treating is outside, and we can all hope for good weather on Halloween. And then having multiple people together, family, friends, and otherwise, who have high-risk health conditions is concerning. And one needs to understand the risk to those who are either older or who have other health risks, and consider that in planning those events and those get-togethers and how they're done. As I said, outdoor gatherings, smaller groups, limited travel is lower risk. And it becomes a matter of calculating how risky the event is and how it can be made safer. Importantly, unless you're outside separated, you need to have masks on when you're inside. And that counts now for vaccinated or unvaccinated folks. Get everyone vaccinated, get everyone in your family vaccinated. You've heard a lot of the data and you'll continue to hear more of the data, and that's important. And, we've said it again before and we'll say it again. One needs to watch the data and be prepared to change plans if something changes, either on a micro level among your family or within the community, and watch the data, and we'll help you do that. And then just basic information. If someone feels sick, they need to stay away from groups. They need to stay away from family groups. They need to stay away from work groups. And that's even more important now than ever. Mike mentioned flu shots, and that's very important. It's not just COVID. We've got flu season coming. We don't know what's going to happen with flu season either. We know we didn't really have one last year because we kept people apart. But as I pointed out to clients, a really weird thing happened a couple of weeks ago. We had large outbreaks of RSV, respiratory syncytial virus, among kids in August and September. That normally happens in January and February. So we put kids together when they hadn't been together for a while, and we started getting infections. That could happen with flu too. So get your flu shots. A couple of things about flu shots as your friend and chief medical officer. It's impossible for the flu shot to give you the flu. People say it does. It makes you feel bad because of the immune response. That's a good thing. You cannot get the flu from a flu shot. People say, I'm healthy, I never get sick, I don't need it. That's not a valid excuse. You are at risk just like anybody else. And if you're sick, stay home. And then, it's just some basic things, be safe, be smart, do all the things we've talked about. The simple things still work. Masks, vaccination, cleaning hands. We're not as worried about surfaces as we used to be, but still keeping your hands clean is very important. And it's very important through the winter for other respiratory viruses. So those are really the key points we wanted to bring up. And I know there are lots of questions. I've seen a few in the chat. I'm going to turn it back to Carissa, and she'll manage the questions. And then the three of us will answer as we have before.
Okay, good evening, everyone. So we'll start with the first question. Are there other variants of concern?
I'll take that at first. Others may win. There are lots of variants. I think we've lost count. If you dig through the sort of the virology literature, you'll find dozens. And we do joke that everybody's going to know the entire Greek alphabet by the time this is over, and they get named now for Greek letters. But there are variants within those Greek letters. There are a couple of variants that the World Health Organization is watching. They're in other parts of the world right now. Delta is still dominant here. But we do worry about other variants, particularly as the virus passes from person to person. So we need to keep an eye out for it.
Okay. Are there any other concerns regarding young children, ages 5, 6, etc., having long-term negative effects from the vaccine? There are people who are worried about reproductive issues, for example, later in life for these children. What are your comments on that?
Zero evidence. First of all, it is scary how many pregnant women who are not vaccinated are becoming critically ill and either losing their baby or losing their own life. So pregnant women should seek this vaccine, and the CDC has made a big point of that. We have no current concerns or data that children should be negatively affected. And there's also I don't know if it's disinformation or just bad information. This notion it was developed too quickly. Oh my gosh, this is not safe. The notion of mRNA-based vaccines has been around for quite some time, and this is their Super Bowl. They have shown that they can rapidly take a virus, cut it down to its genetic core, manufacture this safe and effective vaccine, and save lives. So I, as a pediatrician, have no concerns about the long-term effects. We're going to continue to monitor kids, and pediatricians are going to have the discussion with families, but I am very confident in what I've seen from Pfizer. I haven't seen the Moderna data. They are studying this in children as well.
Okay. Another question. This is with regards to natural immunity. How does it come into play? Another person had actually sent in a previous question regarding this. CDC hasn't considered or isn't considering natural immunity as an effective means to combat COVID-19, referencing a Washington Post article that has had a person that has had COVID doesn't need the vaccine, and this can be supported by blood work to check antibody and T cell levels. So what are your thoughts on that?
So thanks. That's a very good question, and it does come up. And so I'll answer, and then Mike and Emily may have other thoughts. We did get the question with the Washington Post article in advance, so thank you for that, because that did give us a chance to review some of the information, because there are multiple studies presented in that. First, it's not a particular surprise that there is some immunity from being infected. That's how the immune system works. That's how viruses work, and that's a known phenomenon. The question is it solid immunity? Is it long-lasting immunity? Is it effective as variants come up? And how consistent is it after infection? Is it really good after every infection? Is it only the more severe? And some of this we don't know. But I will point out, the Post article was an opinion piece from a Dr. McCary, who's I think I'm pronouncing his name correctly, who's a surgeon at Johns Hopkins, who has spoken a lot and talked a lot about this subject. And he cites 3 studies, and I'm going to just talk about those very briefly. This is not going to be a long diatribe about the studies, but some of them have been pretty well known. There's an Israeli study that came out a couple of months ago that purports to show that those that were unvaccinated but had been infected had a stronger immune response than those who were vaccinated. There's a number of problems with the study, and it's a preprint study, which means it hasn't been peer reviewed. That's not preprint studies aren't necessarily bad, but it's not gone through the rigorous process of looking at the methodology and trying to find its problems to make sure it's publishable. Interestingly, it hasn't been published yet. There's some interesting flaws in this study. There's a bias issue. There's a significant mismatch between the two study groups, which are a result of it being a retrospective study. The vaccinated group had many more health conditions than the unvaccinated group. You can control for that to an extent, but you can't completely control for it. There's something called survivorship bias, which is interesting among the unvaccinated group, given that before the study period, a number of them had likely died from COVID. Some of this comes back to operations research during World War II, and that's, if you want to look up survivorship bias, that's where that initial thing came from. So significant concerns about that study. It's not fully been published yet, so we don't know its validity. A couple of other studies very quickly that were cited. One was a Cleveland Clinic study that looked at healthcare workers that had been vaccinated and hadn't been vaccinated, and whether they got sick or not. And it concluded that because their healthcare workers didn't get sick, that they didn't really need to be vaccinated because their rates weren't as high. It's a relatively younger group, although we don't know because they didn't publish the demographics. It also is a preprint study, and interestingly, the Cleveland Clinic itself came out with a press release right after that saying, we know this study got published, but please get vaccinated because we've looked at the data and we believe the data is solid that people need to get vaccinated. So for someone's own institution to go with a release after a study is pretty remarkable. I don't think I've ever seen that happen. And then a Washington University study that looked at immune response at a chemical level within the body on people who had been infected, and essentially showed that people do retain an immune response after they're infected. The problem is we sort of knew that was going to happen. And in fact, the lead author, and I'm going to quote him because this is important, the lead author of that study right after it was published was quoted as saying, antibodies developed after vaccination should not be a substitute for vaccination, especially as variations of coronavirus strains emerge, which means that person who published that study still believes in vaccination, even among infected persons. So, you know, we're going to learn a lot about this. It's clear that you do get an immune response from being infected, but the data is quite clear, and there are many studies that show that vaccinated persons derive a benefit whether previously infected or not. I don't know if Emily or Mike want to add to that.
I don't know how to top Til's incredible dissection of the literature. I guess I would be a little bit more pedestrian. Why would you risk it? I mean, if you see the number of patients on ventilators dying a horrible death, the number of patients on ECMO, I don't know, and with a safe and effective cadre of EUA approved vaccines, I just don't know why anybody would risk that. And I guess, you know, Til once again did a great job of dissecting the literature. I'm being a little bit more sort of visceral, I guess. I just, with 700,000+ people dead of this virus, I don't know if I would even risk that debate. I don't know, Emily, your thoughts?
I mean, I would agree. And I think when you look at the percentages, it plays out that vaccination is far safer than risking getting this virus and potentially having severe effects, long-term disability from getting a long-term COVID, or dying, or passing it to someone in your family. So I think in the end, vaccination is the safer option, even for folks who have had a natural infection, to ensure that they have enough immune response to continue to be protected for as long as possible.
Great, thank you so much for that answer. I appreciate all that information. That's all actually very, very interesting. Next question is, what about breakthrough cases with people who have been vaccinated? What is the severity of COVID for those people?
Dr. Lankau?
Yeah, so I just pulled up CDC's website to get a sense of the numbers, because numbers are helpful here to get a sense of proportion. We don't know what percent of vaccinated people have had a breakthrough infection. It's not tracked consistently across states. Many people have asymptomatic infections or may not get tested even if they do have symptoms. So we don't really have a great sense of what that overall percent is. But what we do know, because CDC is recording hospitalized breakthrough infections, is that a very, very small percentage of vaccinated people have been reported to hospitals as infected with COVID and hospitalized, or infected with COVID and dying because of that infection. And to give you a sense of the numbers, about 185 million people have been fully vaccinated against COVID-19 as of October 4th. About 17,000 have been hospitalized with non-fatal infections, and 6,617 have died. Those are very small numbers. We're talking 0.01% hospitalized and 0.004% that died. That's very small numbers. These vaccines are extremely effective. Now, the big unknown is how many people have been infected while vaccinated and potentially played a role in transmission. Those are numbers that are harder to come by, which is why the recommendations right now, with such an infectious virus and the knowledge that we know people are getting breakthrough infections and may be able to transmit, although probably less often transmit as those who are unvaccinated, is that we all need to be taking precautions to prevent transmission, whether we're vaccinated or not, when we're in close proximity to others. That's a big unknown, and that unknown means we should take the safest posture possible and wear masks when in public with others, whether they're vaccinated or not, continue with hand washing, good hygiene, and physical distancing when in public and crowded settings.
Thank you, Dr. Lankau. What about during the winter, what can we do to create proper ventilation in buildings or classrooms that are just not up to par?
Yeah, I'll take that. I'll stab, and I'm sure Til will have something to add. I think, pediatricians and public health folks working with school districts has always been around, right? Outbreaks of measles or things like that. I do think those relationships where they're working well are really working well, and that is public health officials coming together with school districts and trying to say, okay, let's first and foremost talk about masks. Masks always seems to be top of mind. But second, how can we work to make it as safe a school as possible? I do think there's yet another tragedy underlying the inequities of this pandemic. And there is some school districts that just don't have the fiscal wherewithal to do everything that the CDC or the AAP or pediatricians recommend. So I think there's some bright spots across this country where school districts are working to diligently make those recommendations live. And unfortunately, there's just inequities in their school divisions or districts, I should say, that just can't afford it. And I think that's absolutely horrible. I do think, however, it does not take a lot of money to do the basics, and that is distancing and masking. And then once we get vaccine out, hopefully it'll be a much safer time for kids. I don't know, Till or Emily, other thoughts?
Yeah, no, that's great. I think, the doing, there's no doubt you could spend millions of dollars to retrofit buildings with all sorts of things, which most places don't have the resources to do, particularly school systems. But the basic things continue to work. And so, the science of ventilation in buildings is a pretty complex one, although we, not the three of us, but others on our team, have advised a lot of our clients on how to do this. It is very important, and to engage with your, if you're responsible for a building or a site, engaging with the owner of the building or the building engineer. This is the time to get to know them and to really, if they haven't already been asked the tough questions, ask them about air exchanges and filters and things like that, to figure out how, in fact, things might be reconfigured to make it safer.
Okay. Next question. What are the differences in the long-term effects in those who do not have the vaccine versus those who do? For example, are those who do not get a vaccine more likely to have heart damage than those who do get the vaccine from contracting COVID? Or do both groups have the same likelihood of long-term impacts when they do get the virus?
Mike, I'm not sure we actually know the answer to that, but Mike.
I don't think we do either. I will kind of come back to what Emily said, that if you are that rare breakthrough case of, tripping positive for novel SARS-CoV-2, having been vaccinated, we know the data is, boy, your clinical course is much less severe. Yes, there are outliers, and they're very sad, very small percentages, but the vaccine seems to protect, number one, most importantly, from getting infected by this, or two, if you are infected, that the outcome seems so much better, much milder cases, much less hospitalization, almost unheard of, not zero, but almost unheard of ICU or need for mechanical ventilation. So the long-term effects of cardiac damage or long haul syndrome or what have you, I don't think we know. I do know it's much worse if you get infected without being vaccinated, that your clinical course is just rudimentary, so much worse. Till, you probably have much better data, Emily, as well.
It's kind of a slightly different level. I don't know the answer to that. I don't think anybody does. I think just from a perspective standpoint, we get asked about long COVID or multiple terms in lots of settings. We're talking about a disease that has been known in this country for, I don't know, 18, 19, 20 months. And we don't even have a good definition of long-term and what those symptoms are as a healthcare system. So, logically, one would think that the more severe cases are more likely to get long-term, but that's not necessarily the case. Some people with minor cases have had some long-term symptoms. We're still looking for a good case definition, and we'll continue to follow that over time.
Thank you. Next question. We've noticed that specific safety guidelines implemented in schools last year have become a little bit more lax this year. For example, no temperature checks or eating lunch in a cafeteria, socially distanced, but by sitting in the child's specific desks. Why is this guidance changing? Would we anticipate it to go back to more stricter protocols?
I think each school district is sort of building this aircraft as they fly it, as they change pilots. I don't know what the right analogy is. I do think I'd come back to something Till said and Emily said. It's about the basics. It's about masking in kids down to age 2, social distancing, and keeping a clean environment. I think there's so many back and forths between, do you take the temperature check at all? I don't think temperature checks, and this is Mike's personal opinion, I don't have a deep knowledge of the data. I don't think temperature checks have been really proven to be that efficacious. So I think school districts, I think one of the toughest jobs in this country right now is being on a school board or running a school, because you're first and foremost trying to keep kids safe and educate them, and then keep up with all this public health changing information. But I'd come back to something that Till said. We just got to stick with the basics, and that is hand washing, it's masking, it's distancing as you can.
Thank you. If you've had the virus, is it advised to wait 90 days or longer before getting vaccinated?
It is 90 days, right, Phil? No, I'm thinking monoclonals. Monoclonals is hard stop 90 days till vaccine. I don't know if the
guidance is somewhat changed. Emily may check me on this. There was original guidance that said that was partly related to supply of vaccine and the need to sort of govern who got it. Once you're symptom free, once you're sort of over the acute illness, I think it would be advisable to go get the vaccine. The guidance has changed on that over time.
Okay. We have 2 more questions in the queue. I think we have time for that. Is hand sanitizing an okay alternative to hand washing? Our schools are not equipped with enough bathroom facilities to allow everyone to wash hands and get to classes on time.
yes.
Yeah, the only caveat to that, yes, Mike is right.
Oh, he's got a caveat for the
The
last
only
question.
caveat to that, that is hand sanitizer doesn't do anything for particulate matter. So if you are out, eating and you get
Soiled.
so there's stuff, you need to get stuff off your hands. That's what soap and water's for. But as far as protecting you from infection, yes, hand sanitizer put on properly is fine.
Okay. Last question. The Atlantic appears to be the source for the slide referencing the effectiveness on face masks. Are there any controlled randomized experiments demonstrating effectiveness of cloth or medical masks or face shields?
Large studies. I've seen the literature and I believe it in my heart, but I couldn't quote you the literature on I would be ethically challenged to randomize kids to not be masked. So I don't know if the data's out there, and it's just sort of the Bible of common sense in my mind. The Atlantic's have been publishing a lot lately.
Yeah, and one thing I will say, and then Emily, I think you're probably going to have some smart data to show us, hopefully, or tell
Always
us.
has smart data.
But it would be ethically wrong to randomize a group to unmasked and masked at this point. There were some very interesting studies. They're retrospective and they're kind of experiential, but looking at jurisdictions that had mask mandates and didn't have mask mandates and tried to match them for everything else, and showed a much higher incidence of disease in those without mask mandates. Now, there may have been some other behavior also, but this replicated itself several times during peaks of last year. Emily?
Yeah, I mean, I would agree with that. And it's difficult to pull apart right now because different parts of the country are going through these waves at different times. But schools that opened in August in areas of the country where masks were actively being discouraged by the governors or by other politicians, and in fact weren't using masks, were often places that we saw lots of school closures happening as we were going up this hill into this peak. Other parts of the country have been very careful about using masks, applying all these layers of protection, and have been able to keep classrooms open. So I think that's anecdotal at this point, but someone will go do that analysis and control for case rate and all of these other factors. And I suspect it will play out that schools that have been very careful to follow all of the guidance as much as they possibly can, given their resources, are likely places that we're seeing fewer school closures and fewer classroom outbreaks. And that probably will play out when someone does a controlled analysis. Anecdotally, I spent some time preparing a talk where I searched school closure and the names of states and was doing that based on what was going on politically at the time. I found a lot more news articles about classrooms being closed down and schools being closed down for certain states compared to others. And it was very much based on their masking policies. I think the data will come in eventually. Right now, this is more spidey sense, but we have good evidence that masks work. And when they're applied effectively, you can have camps where people sleep overnight, and if they cohort properly and use masks properly. There was a great article that just came out from CDC on this, that day camps and overnight camps are doing a great job of controlling infection by cohorting and moving students into groups very carefully and using all of the tools available to prevent infection. And they were able to do this during times that we had very high case counts. So masks work and we need to be using them.
Thank you, everyone. I think that is the last of our presentation, or at least our question and answers. So Dr. Jolly, do you have any last remarks.
Yeah, thanks once again. Thanks, Dr. Anderson and Dr. Lankau for sharing your information and insights with our group, and thank you for listening in. This continues to be a challenging time for all of us. You know, more and longer than any of us particularly wanted to deal with, but you're dealing with it quite well. And we will continue to do these and update all of you and be available, you know, offline and for other questions that come up and for advice as this changes. So thank you very much. And now I'm going to turn it back to Girish. Girish for final remarks.
Thank you very much, Til. I'm sure all of you will agree that the information shared by our esteemed panel is invaluable, particularly as we head into the holiday season, you know, as well as the cold weather on the East Coast. We're going to be indoors more, whether we like it or not. And secondly, as you know, we get to Halloween and Thanksgiving and Christmas and so forth, you know, we want to get together with our families and friends and, you know, be in gatherings. So the information that I think was shared today is invaluable. I think we're going to have to be very judicious to be able to deal with that. So I really want to thank, you know, Dr. Anderson, Dr. Lankau, and Dr. Jolly for giving this, I guess, advice and information to us in such a personal manner. You know, as I say, after many of these calls, the information here is priceless. You know, the ability to be able to ask questions and get such candid response, I don't think can be gotten anywhere else. It's unparalleled. Secondly, I want to thank all of you for joining us. I hope you found, as I said, the information valuable in dealing with, you know, the challenging times that we have coming up in the upcoming months. As the situation continues to unfold, and unfortunately, I wish I could say that this is going to end in the next 30 to 45 days, but I think it's here for the foreseeable future, and we're going to have to traverse it in a manageable fashion. So I hope you find the information useful, and we'll continue to do these town halls, you know, every 4 to 6 weeks, so that all of you that are interested in gaining the information and knowledge will be able to participate and join in. Last but not least, I want to thank you for attending. Stay safe, stay healthy, and, you know, be with your family, enjoy, and we'll see you soon. Good night.